to talk a little bit about just kind of a general overview of some of the material science advances in spine surgery. And in particular, I'm going to highlight some of the work that we did at the University of Missouri with some of the bioengineers there. So I have no financial interest in any of these allografts, or actually, frankly, any financial interest in any product, for better or for worse. And I think this is a fairly timely discussion of this. This was actually a special issue of the International Journal of Spine Surgery. This was actually just in December of last year. So just a few months ago, they had a special issue about the role of bioactive materials in spine surgery. And I think that this is really kind of a key area of research in spine surgery in particular. And I think that the lessons of the advances in these materials, I think, can serve the rest of neurosurgery as well, not just spine surgery. So just start out, mainly going to be talking about allografts today. And the question, especially, kind of the more senior generation of spine surgeons typically have a little bit more sour view of allografts. So, I mean, who cares about allografts? Because everybody knows that autograft beats allograft every time. And for the residents, if you haven't heard this, then you will at some point in your training. And you can't do better than a patient's own bone. And that's a classic refrain. And the question that I've always had is why can't we? Why not? Why can't we do better than a patient's own bone? And just for the record, I actually do believe that this is true at the moment. I do think that there's nothing better than a patient's own bone. But I don't think that that's always going to be the case. And I don't think it has to be the case. So when I talk about allograft, I'm just going to be talking about any structural graft that's not autograft. So just to keep it very simple. So this includes a variety of compounds, everything from DBM, collagens, calcium phosphates, ceramics, biodegradable polymers, and then also scaffolds for delivery of bioactive compounds. So it would include things like DBM in that. And for the residents, and maybe for the non-spine surgeons, I don't think about bone biology as much. Some of the relevant terms in this discussion, kind of three key terms that kind of pop up all the time when you're talking about allografts and autografts and spine fusion, are these kind of three terms. So osteoconductive, meaning the bone can grow through the material. So cadaver bone is an example of an osteoconductive material. Osteoinductive induces bone growth. So BMP would be a good example of an osteoinductive compound. And then there's osteogenic, and that's material that or cells that actually grow new bone. And basically, when people talk about osteogenic these days, they're generally talking about bone marrow aspirate. And then there's things that are none of the above. So, for example, like a peak cage, just a classic normal peak cage, is none of these. So it's not osteoconductive, it's not osteoinductive, it's not osteogenic. It's very biologically inert, and that has certain favorable characteristics for certain applications and not for others. So starting with just as a review of kind of where we're at with some of these things. So allogenic bone graft or mineralized bone matrix, you could think of it that way, is osteoconductive, and I'm talking about cadaver bone here. It's weakly osteoinductive, and it can have variable characteristics depending on how it's processed. Generally speaking, it's equivalent in the long term to autograft for ACDFs, and that's why, for the most part, people don't do autografts for ACDFs anymore, is because you can get equivalent outcomes using allograft, and you don't have to harvest the patient's bone. And unlike autograft, it's available in unlimited quantities, and there's no donor site morbidity. And that's really kind of a key thing, particularly for ACDFs, is we sort of transition to not doing the like crest harvest, except for in certain situations. Some people certainly still do that. But a big reason why that's kind of gone by the wayside is that allograft seems to be the same in terms of outcome. And there's a small risk of disease transmission with cadaver bone that's very tiny, and you generally it's one of those things that you read about more often than you see. Although I suppose some of the more senior surgeons might have seen this in the past, but I've certainly never personally, knock on wood, seen a case of disease transmission. But there is a risk of that. DBM, so we go from mineralized bone matrix to demineralized bone matrix. So that's a really good option to supplement insufficient autograft and spine fusion. There's not really any evidence right now to indicate the benefits of DBM as a standalone osteobiologic. So it's almost always used in conjunction with something else. And this is also very commonly used allograft. Ceramics, just in general, are an inorganic, non-metallic oxide, nitride, or carbide material. These can typically have characteristics of being very brittle, very hard. They tend to be very strong in compression, but weak in shearing and tension. These include hydroxyapatite ceramics, tricalcium phosphate, calcium sulfate, and silicon nitrides. These typically contain a brittle porous microstructure, and that actually enables stem cell migration and adhesion. So this is an example of something that's osteoconductive, that's also inorganic. Bioactive glass has gotten quite a lot of talk. It seems like, from my perspective, it seems like it's gotten quite a lot of talk over the last 5 to 10 years. This is an osteoconductive, inorganic metallic oxide. Usually it's silicon dioxide. That's what most of the commercially available bioactive glasses are. These degrade over time once they're implanted, and the rate at which they degrade depends on the secondary components. So they, like I said, they're primarily silicon dioxide, and then they add usually calcium oxide or sodium oxide in varying quantities. So just a few examples of this sort of technology. There's 3 listed there that are common: Bonalive, PureBridge, and Nanofuse. We use Nanofuse at the University of Missouri, so I'm a little bit more familiar with that compound. But like I said, there's a number of products coming out that try to harness the kind of physical and biological characteristics of bioactive glass. Beyond the actual structure of, or the compound of what you're using, whether it's PEEK or calcium or autograft or allograft or whatever, altering the microstructure of the implants itself can actually greatly increase their biological activity. So porous titanium is a classic example of this. So titanium, everybody knows we put titanium implants in. They, both cranial and spine, they don't change over time. They're very biologically inert. They don't degrade. The body really doesn't react to them. And so it's a very biologically inert compound, which is why we use it. However, if you machine it to have porosity on a nanoscale or microscale, it actually does become highly biologically active. So this is a really, in my mind, kind of a classic paper demonstrating this. And the goal of the paper is to demonstrate a porous titanium interbody cage for T-lifts. And so they used a sheep model for this. We'll talk a little bit more about animal models here in a little bit. But they compared the porous titanium cage to a PEEK cage. So we can see here on the left, this is obviously a sagittal cross-section. This is the disc space here. Hopefully everybody can see my mouse cursor. But here's a vertebral body, here's a vertebral body. This is the disc space. And you see the PEEK. So there's through growth of the PEEK because of its macro structure. So it's got a big hole in the center of it and allows bone to grow through it. But you see where the PEEK actually is itself, the bone is not, it's not adhering to it, it's not growing through it. PEEK, like titanium, is extremely biologically inert, which is, again, one of the reasons why we use it. But I think it's also a key characteristic that can be improved. So when you look at this porous titanium implant here, the implant you see not only has growth through the middle of it, through the macro scale modification of this implant, but you can actually see on a micro scale, the bone is actually growing into this 3D printed porous titanium. And so unlike the PEEK graft, this compound, this graft has been modified on a structural level to help with its biological activity. And just anecdotally, so porous titanium can be either 3D printed or machined to varying degrees of porosity, to just kind of depending on the particular strength characteristics you're going for. But I've actually heard, just again anecdotally, of a spine surgeon who used a porous titanium corpectomy cage, and for whatever reason, and this is still not totally understood, this porosity on a nanoscale of titanium is extremely biologically active, and so it not only induces bone growth, but in this particular patient, it actually grew through the patient's esophagus. And they had to go in and do it. It's just kind of a whole disaster. But for whatever reason, living tissues really, really like microscale porosity, particularly in titanium. And that's not the biology, the bone biology, that is still not totally understood. Beyond making an implant out of, a particular microscale or nanoscale structure, you can also coat the surface of implants with biologically active material, which can induce on growth. So this was in growth, of course, it's growing through the graft. But you can also coat these materials to induce on growth onto otherwise biologically inert materials. And so a really widely known example of this, or widely used example of this, are titanium hydroxyapatite coated PEEK implants. So that's what these look like. And probably the residents have seen implants like this used at some point or another. But this is, again, a PEEK cage, which is, again, very biologically inert. There's, if we go back to here, you don't see any bony on growth, not just in growth, which you have here, but the bone actually doesn't. It's almost like the bone doesn't really like the PEEK. It kind of stays away from it a little bit. Whereas this surface is a combination of titanium and hydroxyapatite, very rough texture, and this helps bony on growth. So this is another example of using inorganic compounds to induce biological activity. And then you can also take biologically active compounds. So we talked about PEEK and titanium, which are biologically inactive, but you can also take biologically active compounds and then modify them on a micro or nano level, nanostructural level, to increase their bioactivity. And so the example that probably the residents at University of Washington will see the most of is magnetos, just because that's used quite a bit at Harborview. So this is a compound that's 65 to 75% tricalcium phosphate and 25 to 35% hydroxyapatite. And it's got the kind of the key feature of this and where they get their intellectual property, what makes it, what the company claims makes it unique, is this kind of nanoscale microstructure. So it's got these very kind of rough glass crystal like structures, and then this degrades over time as it spends time in the body. But just like with porous titanium, for whatever reason, when you start modifying the structure on a nanoscale level, and it's either rough or porous or kind of needly like this, for whatever reason, that does seem to have a pretty big impact on how the body reacts to it and how bone in particular grows onto it. And so when you take tricalcium phosphate, which in and of itself, does induce bone growth, or you take hydroxyapatite, which is, relatively inert, you mix those two things together, but it's not just the composition of the graft that you're using. It also depends on the microscale or the nanoscale structure of what you're using. So that brings me kind of this way of introduction into hydrogels. So this is another compound. These are basically hydrophilic polymers. These were first used back in the 60s to make contact lenses. They've since become a really attractive scaffold material in bone tissue engineering as well. And probably if, before I started doing this work a couple of years ago, I really hadn't really thought of hydrogels, and never really heard of hydrogels. But I would bet that if any of y'all wear contacts, if you go look at your contacts case or the contacts box that they come in, it's likely that the contact lenses that you're wearing are hydrogels. These are highly hydrated 3D networks of hydrophilic polymers, and they can form porous structures similar to the extracellular matrix, which is, again, why these compounds have become so attractive for biological engineers. These have excellent biocompatibility, and they've been around for forever. And importantly, to the work that we were doing at the University of Missouri, they can also serve as carriers for various growth factors. So just as another kind of side note introduction, chitin is probably something that you remember from your middle school biology classes learning about insects. It's a linear polysaccharide that forms the exoskeletons of many arthropods, and structurally it's similar to hyaluronic acid. And it's been shown to accelerate wound healing. It's insoluble, however. Chitosan, derived from chitin, is eminently biocompatible and bioactive, and it readily forms hydrogen bonds. This is an example of chitosan being used in bandage material, and in a lot of this, a lot of the background with hydrogels and chitosan come from the wound care world. These are really commonly used for bandages and suture materials and other compounds to accelerate wound healing. just because of their excellent biocompatibility and their absorbability. So when we combine those two things with chitosan hydrogels, you can link these two compounds. So chitosan can be incorporated into scaffolds with a huge range of physical properties, but actually still retain that bioactive function of chitosan itself. Just as an aside, chitosan hydrogels are also used. This is an active area of research for neural regeneration as well, beyond what I'm going to be talking about. So when I was at the University of Missouri, I started working with a lab group called the Biomodulatory Materials Engineering Lab, or BioMel. This was headed up by a guy named Brett Ullery, who's a really talented, really gifted bioengineer. And he's really most interested in basically coming up with compounds that have biological utility. So he had been working for a number of years developing chitosan hydrogels for as tissue scaffolds and drug delivery. He's really interested in, smart compounds that can slowly elute drugs for different disease processes and stuff like that. And in particular, he really is interested in simple signaling molecules and how that can induce tissue differentiation. And so basically, when I came on board a couple of years ago, he had this really kind of interesting compound and just didn't really know what to do with it. And so when he and I were talking, when I was, I think a third year resident, I was thinking about my fourth year or fifth year as my research year. And I was talking about research ideas. He was telling me about this, and my thought immediately went to use of this as an allograft. So ideally, if we kind of think of an ideal allograft material, we'd want something that's biocompatible, osteoconductive, osteoinductive, and have favorable mechanical characteristics. So in particular, when I say mechanical characteristics, you can think of this in two ways. There's the handling characteristics, because everybody who's done spine surgery knows if the handling characteristics, if the stuff that you're trying to put into somebody has unfavorable handling characteristics, that's not a good allograft, and certainly not an ideal allograft. And it needs to have favorable characteristics from a compressive strength standpoint. So when we talk about controlled release of signaling molecules, in particular, we're talking about calcium and phosphate. These are simple signaling molecules which can induce osteoblastic activity in mesenchymal stem cells, and that's obviously of key interest when we're talking about a spine allograft material. So these, fortunately for us, calcium and phosphate have a very well-defined therapeutic window, below which it fails to induce activity. So if you got too low of a release of either of these substances, it doesn't really do much. But importantly, in the case of calcium, if you're above the therapeutic window, it can be toxic to tissues. And so you've got to have, that's what I mean by this controlled release of signaling molecules. It's not enough to just, spray a bunch of calcium and phosphate ions into a wound and close up. It really has to be pretty exact. So this is what our hydrogels looked like. And these were just some pucks that we made in one of those 6-well chambers. So on the left is what it looks like when we freshly make it, and then on the right is what it looks like after 20 minutes of gelation. And then we take the puck that's on the right, that's totally gelated and solid. Then we freeze dry it and we sterilize it so that we can use it as a graft material. And after that, it still looks like a puck. It's got similar compressive strength actually to osteoporotic cancellous bone. So it's kind of this brittle kind of compound, almost like really osteoporotic bone. And so one of the first things that we did was try to look at the release of these ions that we're interested in. And so this is a pretty busy slide, but you really only need to focus on these green triangles because this was the formulation that we ended up going for. This is just a variety of different different amounts and types of materials that we were tinkering with to try to get a good release of ions. So this is the calcium ion concentration, and this is just in media over the course of 14 days. And so again, with calcium, it can't be too low because then it doesn't do anything, but it can't be too high because then it kills things. And so we looked at this over 14 days, and at every day in that 14-day window, this was the calcium ion concentration was within the therapeutic window. Furthermore, looking at phosphate ions, again, it's a busy slide, but again, just focus on these green triangles. Again, with phosphate, it's most important that you're above the minimum as to induce bioactivity. There's not really a maximum therapeutic window for phosphate. But you can see in both of these that we're within the window for calcium ion concentration, and then we're above the threshold for phosphate ion concentration. So this is from our standpoint, from an in vitro standpoint, this is a really favorable compound because it's got the controlled release of these two ions that we're really interested in. But it's one thing to do it in vitro. It's another thing to take it to the cells and see what they do with it. And so this is looking at the ALP activity, which is a secondary marker of calcium formation. And these are mesenchymal stem cells. So compared to just osteogenic media, so osteogenic media, of course, is media that's been designed to induce bone growth. The C and D, the circle there on the right, is our compound. And so when we incubated cells with this hydrogel, they had significantly higher ALP activity than the osteogenic media. And that results, in terms of the ALP activity, kind of evened out over the course of things, but that initial spike is really important. And then looking at the right side, the ALZ concentration, which is another secondary marker of actual calcium formation, you can see with our graph materials there on the right that are circled, a much higher concentration of ALZ. And it's not really important to get into the weeds of these assays and how they work, but it's just enough to say that ALP is an early indicator of osteogenesis. And so when you have an early ALP peak, which is what you've got with the without later calcium formation, that suggests an incomplete osteoblastic differentiation. And so when you look at at our compound, we got this early spike of ALP, and then again, the proof is in the pudding. The actual calcium formation at day 14 and day 21 is quite high compared to the early ALP activity without concomitant increase in the ALZ concentration. So it's probably getting incomplete differentiation of the osteoblast there, as opposed to our compound, which does seem to be successfully inducing osteoblastic differentiation, which is exciting. So then taking it from cells, we wanted to make sure, of course, that these were biocompatible in a mammalian model. And so we did basic in vivo biocompatibility studies in mice. So we implanted this hydrogel into the biceps femoris muscle of a mouse, and they were monitored for 14 days, euthanized, and then necropsies with histopathology was performed. Just in the interest of time, this was very well tolerated. There was no adverse events. And again, this is not terribly surprising because both chitosan and hydrogels separately have been utilized for a very long time. They've been shown to be very biocompatible. So it's no surprise that a chitosan hydrogel would also be very agreeable to a living organism. So once we completed those kind of initial biocompatibility studies, we wanted to take this into a larger model. So the New Zealand white rabbit is a very well-defined model for spine fusion. A lot of papers that, if you go back and look at the initial papers for a lot of allograft materials, a lot of these were kind of validated using the New Zealand white rabbit model. And just for those of you who've never seen the New Zealand white rabbit, these are not like little bunny foo-foo from your childhood stories. Like, New Zealand white rabbits are very large animals. They're like 25-pound rabbits that are like 4 feet long. They're actually pretty gargantuan. So Wellington Chu, who's an orthopedic spine surgeon at Northwestern, who's an expert in this model, he was kind enough to allow me and my team to visit and adopt his techniques for our studies. But in brief, the way that this works is we performed an intertransverse process fusion, and that's well defined within the model. And so for our experimental for our experiments, we compared allograft alone, hydrogel alone, and then a mix of hydrogel plus allograft in an intertransverse process fusion. We used 6 rabbits per group, so 18 rabbits total, and we took x-rays immediately post-op, 3 weeks and 6 weeks. And then after the 6 weeks, the rabbits were euthanized, and we got 3D CT imaging on these rabbits. So in order to standardize kind of what we're going to call radiographic fusion in these rabbits, We came up, or we didn't actually come up with a scoring system. We adopted a scoring system from another group, where basically these would be double-blinded. We'd have two radiologists looking at these, and they would grade it on this scale based on what they thought the radiographic fusion was. And so 0 being no bone formation, and 4 being a complete fusion. So when you look at our results immediately post-op, no surprise, the score is very, very low. Basically, you can see some bone formation. Again, the radiologists were not aware of when these x-rays were taken, of course, as part of the blinding process. And so immediately post-op, you could see some material within the transverse processes, but no evidence of fusion. And as you go up to the 3-week and 6-week, the hydrogel itself was actually quite favorable. So these are very small sample sizes, of course. It's very expensive to do rabbit studies. And so there's probably no significant difference, but that in and of itself, to me, is a significant result, because we're taking this compound that's totally synthetic. The only aspect of it is that it's a biocompatible substance that's easily biodegradable, and it releases calcium and phosphate ions in a controlled fashion. And seemingly it's performing as good as Allograft in this fusion model. It's we're basically putting plastic into these rabbits and causing a fusion. So these are examples of the X-rays on the left side, and then of the CT scans, the post necropsy CT scans. And really on these, I've found that the X-rays are actually in some ways more or easier to interpret than the CT scans, because these 3D reformatted CT scans, to me, is a little bit difficult to look at or difficult to interpret. But this would be an example of a rabbit with very minimal fusion. We see a little bit of maybe bony formation. This is just allograft. That's what AG stands for. On the CT scan, you still have the material in place. It's possible that this rabbit might go on to fuse at some point. But looking at these two rabbits here, so this is the chitosan hydrogel by itself, and then this is the allograft plus chitosan hydrogel. You can clearly see on these X-rays bone formation on these transverse processes and spanning these transverse processes. In particular, this is a particularly compelling picture of a bony bridge between these transverse processes, and that's the allograft plus hydrogel group. This is what I think is a really beautiful picture for a number of reasons. For one thing, it looks like some sort of thing that you'd see in the Louvre, but on the other hand, it's very beautiful because it actually shows the black stuff is the hydrogel particles, and the blue is mature bone. And so you can actually see, if you were to zoom in a little bit closer, there's actually bone growing through the hydrogel, and the hydrogel itself is well integrated into this. The spacing and separation is just a post-processing artifact, but the hydrogel itself seems to be very kind of agreeable for bone formation. So when we talk about the future of allografts, in a broader picture, material science in general, and then tissue and bone engineering in particular, has rapidly advanced in the past decade. So I do think that the next generation of allografts will be osteoconductive, osteoinductive. They'll have modifiable mechanical characteristics. And what I'm envisioning there, and what kind of got me inspired, thinking about this project is, what if you could look at a pre-op CT scan, for example, determine the density of a patient's bone, and you could have a custom interbody cage that matches that. We've all seen the pistoning of graft material through brittle bone. And I think that sort of one-size-fits-all approach, I think, is going to go by the wayside as material science advances. But the other thing is that we'd ideally like to have a variety of different delivery methods. So one of the favorable characteristics of these hydrogels is that when you first make them, before they gelate, they're actually liquid, so they're easily injectable. So that was another favorable characteristic I'll get to in a second. But in short, the future of allografts, I think they're going to have all the characteristics of autograft, which again is the gold standard, but without the donor site morbidity or the volume limitations. And certainly, when you talk about minimally invasive spine surgery, and I came here to learn endoscopic spine surgery, you typically don't have abundant abundant volume of autograft. If you're doing a minimally invasive TLIF, you're very limited in how much bone graft you actually remove from the patient. It's one thing if you're doing a big T10 to pelvis or something like that. But again, ideal allograft, and that's kind of the benefit of allograft, is you can have it in unlimited supply. So since I've left the University of Missouri, they've explored this. We were trying to when I was there, we were trying to troubleshoot this model. But since I've been gone, they've started doing an osteoporotic compression fracture model to further investigate the properties of this hydrogel. So in this particular study that they just presented at NASS a couple months ago, they had 24 skeletally mature New Zealand rabbits. They overectomized them and they gave them dexamethasone daily over the course of 27 weeks to induce osteoporosis. And so they were successful in this. So they got an average Z-score of minus 2.92. And then they took these rabbits, these osteoporotic rabbits, and then did vertebroplasty with either PMMA, which is kind of what is usually used, or the hydrogel. And so just to show their bone mineral density over the course of weeks, this would be when they operate on them, it's 0. This is when they started. These are two radiographic markers of bone mineral density. And you can see over time, looking at L4 and L5, this general trend downwards in bone density over time. So the procedure that they did, and this model of doing a vertebroplasty, so they did this open, they drilled L4 and L5, and then they confirmed with X-ray that they were in the right spot. And then they injected this hydrogel. And like I said, the hydrogel before it gelates, so when you first mix it up, you've got about 15 minutes or so to inject. They also included a radiopaque dye just to make sure that we were injecting in the correct place, and then they closed up. So one of the interesting things that they found using this hydrogel as a vertebroplasty substance is that over time the bone mineral density actually improved in these rabbits, and so these were representative CT pictures. But you can see on the top here, this is they've started calling this hydrogel cellular gel now. But you can see where they injected. But if you look at this cancellous bone here compared to the relevant controls here and here that were just that were injected, which is saline, you can actually see an increased density of these trabeculations here compared to here. And you saw this also with interestingly, a little bit with the PMA, but the PMMA, excuse me, but you saw to a greater degree with the cellular gel. So potentially, maybe this has something to do with that controlled release of ions that we're saying. Again, the kind of initial use of these chitosan hydrogels in this lab was actually for use as drug delivery. And so this is kind of a rethinking of vertebroblasty in a lot of ways, because this compound, when it gelates, has very similar mechanical characteristics to osteoporotic bone, but it's also constantly releasing these phosphate and calcium ions into the surrounding bone tissue. So it's both a structural additive to the spine in the same way that PMMA is, but it's also it's taking an active role in the bone biology, unlike the inert nature of PMMA. And this is again just showing the post-vertebroplasty bone densities, and it seems to have similar characteristics to PMMA and better than the controls. And so this is obviously a very early phase study. There's a lot of validation to be done and a lot more experiments to be done, a lot more replicas to be done to be sure. And right now they're working on the histological and biomechanical studies, and that's really, I think, going to be key to validating this compound. So just to pivot just slightly, I think that it's relevant to include in this discussion, how do we as spine surgeons evaluate novel materials? And this is kind of a jungle, as it were, an academic jungle that I didn't know really existed until I was kind of wandering into it when I was trying to figure out how we were going to validate our own compound. And I'll say that our previous performance is really not encouraging. So this was a paper, there's actually a number of articles about this now. This is a pretty well-publicized topic. But we as surgeons are really not good at judging fusion. Not only are we not good at judging fusion, we can't even agree how to judge fusion. So For some, in some papers, kind of in the ACDF world, they look at just plain X-rays to see if patients are fused. Some say that you have to use CT. Some say that you have to verify with the CT that the posterior elements are also fused, so that the set joints are also fused. Some papers say you got to do a flexion extension X-ray and ensure that the patient is not moving. And other people say that it's basically irrelevant what the radiographic fusion is, and you only have to look at the patient outcome, the actual patient reported outcomes for pain and things like that. So when they looked at this, when you think about it, it's kind of more troublesome the more you look at it, the more you think about it. And so when they compared a surgeon and his own patients, they compared his radiographs, his patient's radiographs, when they had them reviewed by a panel. So, if you look at this table, so the surgeon said that these patients were clearly fused, and the panel agreed on 74 of them. There were some patients that the surgeon said were clearly fused, that the panel said that they were clearly not fused. And again, this is a panel of surgeons, so it's not like just a panel of folks off the street. And that's at 3 months, and then even at 6 months, you've got one person, the person who operated on these patients, saying, "Oh yes, these patients are clearly fused," and then you've got this panel saying that they're clearly not fused. So that's pretty troublesome. And of course, we surgeons are humans for now, and they noted that the lack of agreement was increased when the surgeon judged the patient had improved clinically. And that's classic. Of course, we as surgeons want our patients to heal, that we want them to feel better. And when they come in saying, "Hey doc, I'm feeling great, my neck pain is gone," and you get an X-ray and it's sort of equivocal, but it's like, hey, they're doing great, they must have fused. Okay. But if you're looking at this objectively, which ideally we would be when you're looking at the radiographic evidence of fusion, how they're doing clinically shouldn't actually matter. When we're evaluating a new graft material, a key aspect of that is trying to figure out, is the patient actually fusing? Is the graft material doing what we're claiming it does? And so this is, again, it's one of those things that is kind of more problematic the more that you think about it. When you think about the number of graft materials we've got out there and how they're actually being evaluated. The AO Spine is working to improve this in terms of the classification of evidence for different allograft materials. And so they've come up with a score, which is relatively straightforward. It's an ABC, sort of like their fracture classification. So separated into human, animal, and in vitro studies in grade 1 through 4, 1 being the strongest degree of evidence. So for example, when you look at BMP, that's an A1. So that's in human studies, it's got prospective randomized controlled trial, which shows statistically significant improvement. And then these various DBMs have varying degrees of evidence. So not all DBMs obviously are the same, and they're not all the same in terms of the strength of the evidence. I mean, we're looking at these two here that are both A4. So these are uncontrolled case series or lesser quality retrospective cohort studies versus a prospective cohort study with graft on DBM. So that's just one example of that. And lastly, just, can't take any opportunity to speak to so many distinguished surgeons without getting a little bit on my soapbox. And again, this is strictly personal. This is not the view of the University of Washington, of course, and they'll be the first to tell you that, I'm sure. I think from a personal perspective, I think it's really difficult to assess data because there's such a high risk of bias. And particularly not just surgeon bias, but also since almost all studies are funded by the companies actually making the graft. And there's also really troubling to me, and I hope it is to y'all as well, there's an increase in private equity presence as well in the spine market. And that's driving up the prices of allografts, and that's making independent studies even less feasible. And this presence is not always obvious. They're very, very sneaky, and there's usually several layers of company ownership. So this was a news article from April 2022. Now, this was a product that I was actually interested in, and that's why I was paying attention to this. So I've hopefully hidden everything that identifies this company, but this was the announcement. So it's this private equity firm that has a very private equity firm kind of name that would immediately be recognized as a private equity firm. Their portfolio company, which has a medical sounding name, that's a shell company, acquires the company that actually makes the product. And so when you're using a product, it's like they always come up with some sort of fancy name for the product, and the company usually has some kind of, cool, futuristic, healthcare related sounding name. And so it's like, okay, well, this product is made by this healthcare company, and there's so and so doctor that's on the board of this company. But what you don't realize is that that's actually owned by another company, which also sounds medical, and it sounds vaguely like maybe physicians or researchers or somebody that actually takes care of patients is involved in. But that company is actually owned by a private equity firm. And so even though, unless you do some real deep digging into these products, you never realize that these products are ultimately owned by private equity firms. So on the other hand, the prioritization of healthcare by private equity is separately a good argument to never use the latest and greatest in allografts. So you can ignore everything I said in this talk because the insidious effect that this may eventually have on our industry. And this is how we've ended up with a single allograft bone anchor costing $1,500. And that's what I was at a dinner learning about this bone anchor. It's like, this is great technology, and looking at the research, it's all great. Talking to PhDs, and I asked them the price, and it's $1,500 per. And I did a deep dive into this company, and sure enough, they're owned by private equity. And that's how we end up with things like that. You got to be careful with the mental gymnastics to justify the costs, because you or the company can always figure out a way to explain these exorbitant costs. They'll say, well, it's lower revision rate, or it's quicker surgery, or less OR time, or whatever. And you can always justify that to yourself, but sooner or later, some non-specialist is going to take a look at this, and they're going to judge that it's totally ridiculous on its face. And if we don't scrutinize these costs, somebody else will, and we probably won't like what happens next. That being said, the future of allograft technology is bright, because we as spine surgeons, and more broadly, we as neurosurgeons, we benefit from the enormous investments into material science research. And material science is a massive field that's growing exponentially. And we stand to benefit from that, but only if we can harness that technology to help our patients. So the next generation of allograft should be better at fusing the autograft, and will have readily adjustable material properties for a wide variety of applications. We just have to make sure that they're also safe, effective, and reasonably priced. Thanks very much. This is Brett Ullery, who is my PI back at University of Missouri. This is me and Blake Darko, who did a lot of the in vitro stuff. This is at Wellington Shoes Lab. I'm sure all these guys, these were all medical students at the time. They're final ortho bros now. And then this is August Himmerla, who's a MS candidate back at University of Missouri, who's doing the vertebroplasty research. So thanks very much.
Thanks. Thank you very much. That was a really beautiful overview. Nice work. I'm familiar with the chitin work, actually. Questions from our academic colleagues?
Hey, Joe. It's Christoph here. Really nice talk. Really appreciate it that you give us this overview, which is so important. There's a couple of comments throughout the talk that I wanted to make here right now. I think it's really important for you not only to think about the surface topography, but also the surface properties in terms of being hydrophobe versus hydrophilic. And I think that's also something that, in addition to the surface, microstructure, that is really important. So this is, for example, why we use not PEEK but hydroxy PEEK, which is actually hydrophil. And so it actually changes the properties entirely. So I think that's something that is really important to name. And the same is true with nanostructures, that it sort of changes that relationship to liquids. The other very important thing that I think should be named too, the reason why we are out for these new materials is actually the elastic modulus. And so there's a big controversy in the field, what type of material is best. And that's the main disadvantage of solid titanium, right? That the elastic modulus is so low that, it's much stiffer than bone. And so that's why PEEK is so popular, because it resembles the elastic modulus of trabecular bone. And lastly, what I wanted to bring up is, I think that you kind of mentioned that the allograft was not a big deal, but in my practice that switched over all allograft for two reasons. For the COVID pandemic, there have been a couple of companies that had to put black label warnings on their products, especially a couple of DBMs, with contamination of TB. And the second thing is every patient, you have this discussion before, and you saw it even yesterday in clinic, right? Two patients brought it up. Do you put cadaveric bone into me? It is a big deal for patients. It is unlikely, yes, but if you have one patient in your career that has TB from a bone graft, it's too many. Because I agree with you, the way you introduced is that it's surprising that this type of bone graft and substitute is not better than allograft yet. And I think what we have done at Harborview, I think we are better than allograft by far already with our products that we use. And the cost is just a little bit for you to think about. Modern hospitals are so difficult, and I know from a couple of these companies they actually don't run positive with their prices, but they actually negative. And the reason for that is they need such a big workforce to get into these hospitals, negotiate, and kind of like maintaining that, and it's sort of it's crazy how many people they have to negotiate and trying to get their product into different sort of hospitals. It's kind of like almost like a little bit of a fight and war. So you're not going to get a bone graft for $50. It's just not going to happen.
Yeah, no, something that was really shocking to me too, and I think all those are really good points. Something that was really surprising to me when I was I think it was in last year when I was at University of Missouri. The PEEK corpectomy cages. I mean, PEEK has been around for 50 years, and PEEK corpectomy cages are not cheap. I mean, just because the material's been around, just because it's simple, doesn't make it cheap. And so the cost aspect of these, it's a big problem. And certainly, when you're talking about the world of allografts, these are expensive to validate. They're expensive to do all this research. These rabbit experiments, which are very, very basic, minimal experiments, are extraordinarily expensive. So it's very expensive from start to finish. And that's definitely that's a major hurdle for sure for all of these.
But again, I just, to respond to that, I think you have to see it in relationship to the apparatus that all of this has to go through. And again, the issue, if you don't have a price tag to it, and the same is true for neurosurgery, any other procedure too. I mean, I think, and again, I don't know if Sam Browder is here right now, coming from the more investment side of things. Compared to what one single administrator that sort of like they negotiate with costs, there's all peanuts. So again, I think the cost needs to come down. I think all over the cost needs to come down. I think for us as surgeons, the most important thing is patient safety and good outcomes, and that really sort of like we can is more important than anything else. Great talk.
Thanks.
Any other people that want to ask questions? Is a good question, Christoph. Anybody?
Joe, the least surprising finding that you reported was that there's no agreement on how to measure fusion or among surgeons as to whether it has occurred. And you're not going to get much private equity funding to investigate that problem. But you need to remember it. It's really important. It's very fundamental in the evaluation whether this is really doing good or not.
Yeah, absolutely. And we've not only got the radiographic variable, but it also is really important to remember that the patient outcomes are really important with these graft materials too. And so it really has to be sort of a 360-degree evaluation of these materials to be sure.